can change. So this was a 75-year-old army man who came with severe anemia, weight loss and a cough. When he came, his hemoglobin was just 4.3 grams. His MCV was 54. His ferritin was 3.5. His WBC and platelet were absolutely normal. In his other history, he was a heavy chain smoker, just never stopped smoking, and he complained of back pain and a past history of tuberculosis. So in the emergency, we had to give him 4 units of blood transfusion, and of course we had documented iron deficiency, so we gave him an iron infusion. But obviously we needed to find out the reason for his iron deficiency, as he had no obvious source of blood loss. So on examination, he looked very thin, hectic, he was drowsy but arousable. So we did a routine investigation, and this was a chest x-ray. So if you see on the left upper lobe, there was a shadowing. So elderly man with weight loss, heavy chain smoker, anemia and left upper lobe shadowing. Something that goes on in our head. The first thing we thought was this man has got a metastatic cancer. Right? You have a shadow, you have a history of smoking, you have weight loss, you have anemia, you have back pain. We thought it is a metastatic cancer. So going step by step, a chest x-ray, a CT scan of the chest was done, and this did not reveal a mass lesion. It showed there was infection with some cavitation. Anyway, we were still thinking that maybe malignancy. A PET CT was planned but could not be done because he was never fit enough. A pulmonologist saw him, a bronchoscopy was done which showed mucoid secretions. There was infection in his biofire panel. TB PCR was negative, but the bronchoalveolar lavage galactomannan was high, which indicated a fungal infection. Also his aspergillus antigen was high. So that was one section. But does that explain our severe iron deficiency anemia? Still, it doesn't. So we did look for blood loss. We did a stool local blood test, but it was negative on 3 days. However, the patient did give history of a melenic episode a few weeks back. So an endoscopy and colonoscopy was planned, and an endoscopy showed a large ulcer in his stomach, and the colonoscopy revealed grade 1 hemorrhoids. A biopsy was taken from the ulcer, and since we could not do a PET CT, a CECT was done. This was normal. So when you look at the overall picture, he came with just an anemia. There was nothing else that we could pick up, but it was a chronic aspergillosis in an old TB lesion and a stomach cancer, the biopsy which confirmed an invasive adenocarcinoma causing severe iron deficiency anemia. So my point here is we have to go into the reason of iron deficiency. I think it has become now a very common practice to give patients iron infusions. They are done at home, they are done in settings, but without really finding out the background of why this patient is iron deficient. If it is nutritional, I think there is nothing to lose. But if we are missing causes like, periods, heavy periods, they've got menorrhagia, or they've got bleeding piles, or they've got GI stomach cancer, until we address the reason for the anemia, we are never going to be able to cure this, and the patient is going to be coming back and back. So my message would be we should treat the anemia, find the cause and treat the cause where possible. Otherwise only half treatment will be done. I'm quickly just going to go through the benefits of iron infusion, and this was just a short summary which we did last year, where we went through all the data of the patients who received iron infusions. In a total population of 108 patients, total iron infusions were 156. Half of the patients required 2 infusions. By this I mean to highlight that just giving 1 infusion is not enough. The full dose may require 2 infusions as per the hemoglobin and ferritin levels. Ferric carboxymaltose was the most common preparation we use. However, some patients who have had previous hypersensitivity, we also use the isomaltoside preparation. The dosage is very straightforward. It is 15 milligrams per kilogram with a maximum infusion of 1 gram at one sitting. When we want to repeat the infusion, we give a gap of minimum 1 week, but I prefer 15 days because this allows the iron that you have infused to go act and make hemoglobin. Otherwise, if you overload the system with the iron, it will just get excreted or give toxicity. Pre-medication, sometimes it's given routinely, but however, it is not mandatory to give pre-medications as the risk of reactions are low. And I have to say that we do not observe serious reactions, but mild hypersensitivity like rash, headache, and some people can get low phosphate levels and complain of pain the following day. So what we saw, the lowest hemoglobin at presentation was 4 gram, between 4 to 9 grams. All of them had confirmed and documented iron deficiency with a very low ferritin. And what we see, the hemoglobin response increases from 3 grams to up to 8 grams, and there are many patients in these, even with low hemoglobin, that we did not have to do a blood transfusion. So I would say, unless the patient is elderly or having other comorbidities, we can conveniently avoid and skip blood transfusion and just treat them with iron infusion. So of course, if they need 2 infusions, the hemoglobin rise was better. So again, if I look at it, these were the long list of diagnoses that we had in our patients who had been diagnosed with anemia. So until we go up to the bottom of the disease, we are not able to treat, and these patients will be coming back to you. So what is the use of iron infusions? We do not have to give unnecessary blood transfusion. It causes a rapid rise in hemoglobin. Within a week, you're going to see 3 to 4 grams are increasing. So it is very convenient. There are very few side effects, and we do it all in a one-stop clinic. And I think what's important is in the pre-operative cases, when patients are getting surgeries and we know their hemoglobin is 8, it is better to optimize it rather than give transfusion during surgery. So that was one sort of, iron deficiency and how it can lead to a different diagnosis. Now I'm going to take you through a slightly more deeper hematological case with a young man, 31-year-old, who presented with again severe anemia, and not just anemia, he had a pancytopenia. He worked with the police, and when he came, his hemoglobin was 4.6, his MCV was 118, total count was 1200. In the differential, there was 30% were neutrophils, there were no blasts, and the platelet was 32,000. So, as a routine, we check hematinics for all patients. His ferritin level was normal, but the vitamin B12 was very low, below the limit of detection of the analyzer. I have presented even before that severe B12 deficiency can cause pancytopenia, and we often land up doing bone marrow tests, while it is advisable to give the iron infusion and wait for a week or 10 days. If it is pure B12 deficiency, you will see the peripheral blood will return to normal. So that's what we did. We gave B12 and we waited for 10 days. So, but after 10 days, his hemoglobin was still only 7.2, and there was no difference in the total count and platelet count. So this obviously means that pure B12 deficiency was not the only diagnosis. So we then proceeded to do a bone marrow aspiration and biopsy, and it came out to be a case of an aplastic anemia. So it's a case of severe aplastic anemia. Now aplastic anemia is what? It's a bone marrow failure resulting from damage to the hematopoietic stem cells, and it causes a complete marrow shutdown. Patients will have symptoms of severe weakness, infection and bleeding. Sometimes we don't find a reason for it. It may be immune mediated, or it can be congenital, as in Fanconi's anemia. till date, allogenic stem cell transplant is the only curative option, but it is only doable in suitable patients. This patient was definitely suitable. He had two brothers, but both of them were not fully HLA compatible donors. And there is good guidelines, because this is not a cancer, we should try and avoid high risk transplants. So he could not undergo an allogenic stem cell transplant, and the next best care was to give him a horse ATG, which he received for 4 days, and cyclosporin, which is as the standard protocol. Within 3 months, his bone marrow recovered, he remained in remission, became transfusion free, and he was well for 2 years. Then again he developed fever and pancytopenia. So obviously our concern was, is his aplastic anemia relapsed? So a bone marrow was done, and this time again there was no evidence of aplastic anemia, but something called hemophagocytosis, where there is an overactive macrophage system which eats away all your normal cells like the red cells, white cells, and you get a pancytopenia. In his case, the diagnosis was a scrub typhus infection which caused the HLH. He was treated with steroids, and once again he got better. 2 years had passed. Again his counts started dropping. So once 3-4 years are gone by, you start wondering whether are there any secondary changes happening in the bone marrow, or is it again a relapse. So this time also the bone marrow was cellular, but what we saw, there was lots of dysplastic features. That means the treatment in the past has damaged his bone marrow, and he got this abnormal cytogenetics, which is monosomy 7, and this is a very high risk marker that if we do not treat this patient, he will go into a transformation to acute leukemia. So this is a very, very common side effect of ATG, which we see over 4 to 5 years after the initial treatment. So now he doesn't have aplastic, he has got a high risk myelodysplastic syndrome. If you remember, we told at the beginning that he had two brothers and both of them were only half a match. So, but this time, we had to take the risk, because if you don't transplant him, this young man would die. So, a 5/10 haploidentical stem cell transplant was done. He is now in remission and recovered from, in one single patient, he had megaloblastic anemia, aplastic anemia, scrub typhus, HLH, and secondary MDS.
Dr. Shilpa, 5 minutes left. Please come up.
Yes, very much less. So again, the highlight of this case is what is in front of our eyes may not be the whole picture. It is very, very important to go deep down into the diagnosis, tease out till the bottom, so that we can get as successful outcomes as we always desire. So anemia is not a sign, it is a sign, it's a sign, it's not a diagnosis. If we diagnose someone with anemia, just replacing it is not enough. We have to find the underlying cause, and it is important that there are overlapping clinical features, so we make no assumptions, but we work with what we have got. So for that, I do run this fast track anemia clinic. It is a model based on Guy's and St. Thomas Hospital in London, where it is a one-stop solution. We have a panel where we get the reports within a couple of hours, so we know in which direction we send our patients. Do we just give them iron infusion and send them home, or do they need an endoscopy or colonoscopy, or do we dealing with pernicious anemia, or anything more serious requiring a bone marrow test? Because it's not, we cannot do blanket investigations. So it helps us in optimizing hemoglobins before surgeries, because you want to avoid intraoperative surgeries, and we can pick up the underlying cause much early because of a targeted investigation, and this leads to better outcomes. And also in today's era, we have to be very cautious about the medico-legal it shows that we have not missed a diagnosis. With this, I would like to thank you for your attention, and I want to thank Dr. Reddy's for sponsoring this session so that we could highlight our experience. Thank you very much.
Shilpaji took a lot of pressure on her throat in delivering the lecture, but now she is present in every FPACON. I have seen her repeatedly coming in every FPA conference. Please come down, Shilpaji, to receive your memento from Dr. Prakash Sancheti, one of our executive committee members of the Family Physician Association. A round of applause because she has taken so much pressure on her throat in delivering the lecture. She deserves a round of applause. Okay, now Dr. Shakil Akhtar to proceed with the next session.
I will invite Dr. Krinjal Shankar Majumdar and Dr. Sabyasachi Basu, co-presenter. Their topic is head and neck cancers. How does an early diagnosis make all the difference? Demystifying plastic surgery and displaying its magic. Okay, ঠিক আছে. He is an ENT surgeon, head and neck cancer dealing oncology, associate fellow American College of Surgeons. Now he is working with Narayana Health, R.N. Tagore Hospital, Kolkata. I will request him to please go with this topic.
So, thank you. Hypopharyngeal and even early supraglottic malignancies, it's finding its incidence or indications in post-CT-RT, post-chemotherapy, radiotherapy, residual and recurrent settings as well for early tumors. So these are the robotic surgeries done through mouth without cutting open the neck. Remote access thyroid surgery, we call it remote access because it's not like the conventional thyroid surgeries which bear an incision in front of the neck. As we know that thyroid cancers are most commonly seen in young females where cosmesis is a major concern. So with help of robotic arm, what we can do is we do the same surgery but we go or access the neck via axilla and periareolar access, giving a better cosmesis with equal oncological outcome. Last in the list is sentinel node biopsy. So sentinel node biopsy is an alternative to neck dissection where we don't do a complete neck dissection. We just pick up the sentinel node.
Just a minute, Dr. Govinda, just a minute. Too much talking is going at the back. It is impeding the speakers. Too much talking is going at the back.
Excuse me, delegates, please don't talk too much.
I request all the delegates to please keep quiet and finish our sessions in time.
Please.
Carry on, please.
Thank you. So we use near infrared imaging as shown in this. So this is the near infrared camera. So it does not require any kind of special preparation. We just simply open the neck, focus this on the neck, and we find the first glowing node. We take that out, send for frozen section, comes as negative, we close the neck. We don't do a proper neck dissection also. And we have mounted evidence also. So we have class 1 evidence, both randomized control trial, one from Japan, one from USA, showed a non-inferiority over a formal neck dissection for early stage neck node negative oral cancers and oropharyngeal cancers. Now, as a community, so these are the institutional statistics or the statistics. As a community, where do we stand in India? So these are Indian data by ICMR published in 2023, and as we can see, from 2015 to 2025, there is an almost 37% to 40% rise in mouth and tongue cancers. If we go globally also, we are now ranked third after China and USA in the incidence. But where do we come second is on the mortality. So as you can see, after China, the mortality is high in India. Why so? Because it again turns out to the same thing, that the stage and survival does not go hand in hand. So it's always an inversely proportional relation. And this is what we cater now. 70 to 80% of our patients present in stage 3 and stage 4, giving us limited choice of therapy and obviously cure. So this trend is again by Globocan WHO, and this is an Indian data with a predicted almost 57 to 60% rise in cancer incidence by 2040. So this is where we stand, and keeping this data in mind.
Dr. Krinjal, 2 minutes left.
Yes, sir. So what we require now is just to change this wheel of fortune to this. We need more stage 1 and stage 2 on the diagnosis rather than stage 3 and stage 4. And that's how our data will improve and almost match the US data or Western countries data. So this is what we achieved at the institutional level. A multidisciplinary team taking care of the patient with the patient in the center. This is the core team with a form of the non-core team comprising of palliative care physicians, psychologists, interventionists, everyone. But this circle is not complete unless this circle is supported by a stronger and a bigger circle comprising of all the eminent physicians like you with a greater reach to the community and strengthening the triad of high risk screening, early diagnosis and appropriate referral. So I thank you all for your patient listening. This is our team oncology from Narayana Arentagor Hospital. We do subsite specific practice for a better outcome and patient orienticity.
Thank
So
you, Dr. Kinjal
Thank you.
Majumdar, for
Doc-
your presentation.
Dr. Majumdar, please stay back for the memento presentation. Please stay back. It will be done after Dr.
Our
Sen.
next and last
Dr. Basu completes his speech.
Dr. Mary D'Souza, you
No.
will speak about the medical ethics.
No.
Sorry.
Sabyasachi Basu.
On the same subject.
Dr. Sabyasachi Basu.
This part of the program is supported by RN Tigor Hospitals, Calcutta. We thank them for their support.
Something's wrong.
Dr. Basu is a plastic surgery consultant at
Just a minute, there's something wrong with the font that's not working here. এটাতে আসছে না বুঝতে পারছেন লেখাটা দেখুন না হচ্ছে না এভাবে দেখিনি
Let me introduce you. In the meantime, the correction will be done. Dr. Sabyasachi Basu is a senior resident in consultant though. কি হচ্ছে সব?
Shit. Shit, তাড়াতাড়ি দাও যেটা সিস্টেমের প্রবলেম হচ্ছে
এসব করে 5 মিনিট লস্ট হয়ে গেল।
If you can, please proceed with the talk.
কোথায় দেবো তাড়াতাড়ি বলো কপি করছি কোথায় দেবো
As he sorts out his technical problems, may I have some announcement? There is a high delicious tea at the end of the conference, so everybody is requested to participate in that high delicious tea. Delegate kit will be distributed from the ground floor of this auditorium in the cloakroom. From the cloakroom, the delegate kit and the early bird prize will be distributed. So go down to the ground floor at the end of the conference and cloakroom 2 and head off for cloakroom 2, and you can form a queue over there. The delegate kit and the early bird prizes will be distributed from there. Near gate number 4. And a high delicious tea is awaiting you at the end of the conference, so do not miss that before going home. Is Dr. Masu ready? We have 2 more sessions and we'll have to finish with a session on medical ethics. As is mandatory nowadays with the West Bengal Medical Council, any conference offering credit points, CME credit points, must have a session on medical ethics. So Family Physician Association also have arranged for the same. Dr. Mary D. Cruz will be speaking on medical ethics at the last session of the conference. But before that, we have got one more session. Please ensure your signature before you leave the conference, otherwise your CME credit points may not be achieved. Please ensure your exit signature at the end of the conference, otherwise your CME credit points may not be achieved.
Those who have registered earlier for the credit points, they will be only receiving the credit point certificates. Okay, thank you.
Now, if they don't sign at the entrance and the exit,
Sign is a separate thing. I am saying that those who have already registered for credit point certificate earlier, they will be only getting the credit point certificate. And they have to sign at the time of exit.
I'm ready, can I start?
yes, start off please.
I would like to sincerely apologize for what has just happened. I'm sorry for that. So this is about plastic surgery.
Please continue, please.
10 minutes is very short, so I will just breeze through a photo gallery. Please just give me some time. This is demystifying plastic surgery. I am Dr. Shobhusha Basu. I did my MCH from Bombay and I was working in Tata Memorial Cancer Hospital in Parel, and then I was a fellow in aesthetic surgery from Delhi. Now I am consultant in Narayana Health, RN Tagore, NSH and Narayana Multi-Speciality Hospital in Howrah. Just a note to gurus before we start anything. This is my guru, Tata Memorial Hospital. Now, how many of us know that the father of surgery was a plastic surgeon? He lived in Banaras, wrote the Shushruta Shamhita. His principles are still followed to this day. And India gave plastic surgery to the world. Different dimensions of plastic surgery: cosmetic, reconstructive, pediatric plastic surgery, diabetic foot ulcers, non-surgicals, burn. We'll go through all of them. I don't call myself a specific reconstructive surgeon or a cosmetic surgeon. I call myself a plastic surgeon. So we do all types of work. Every type of plastic surgery. It's not about any specific region, organ or disease, not the head, neck, not the leg, nothing. It is about a set of principles. It's a problem-solving branch of spine. It treats deformity, uplifts the confidence of the patient in society. Now the flap and graft, we keep thinking flap is only a tissue, graft is only a tissue, and flap you take along with the muscle and the skin and the blood supply along with it. Sometimes we get away only with the graft. Sometimes flap becomes necessary but gives very good results. Sometimes it's only local tissue arrangement, while other times you see this is a huge defect. Dr. Kinjal was just speaking about the oral cancers. Now once he is out of the OT, after he has dissected it, taken it out, now in walks the plastic surgeon to reconstruct. What happens to the defect otherwise? You have to reconstruct the part. You have to return the swallowing function, the speech function. This is a tongue that is out. This was a case done here in RN Tagore. And then we had to make the tongue out of a flap from the forearm. And then finally the patient was this. He can talk, he can well vocalize, and he can do everything fine. Can you hear that? So it is, the plastic surgeon does not have an option as to what he is going to reconstruct and what he cannot. Plastic surgeon has to reconstruct what has been excised. So come what may, whatever, however big the size, we are there, we'll come and reconstruct it. So this is the eyeball that is gone, and then we put back something. We don't put back the eye, but we put back something. The cancer of the oral cavity, so much of a defect, if you see this defect. And then we again harvest a flap from the thigh, and then we cover it up, and the patient goes back home with dignity, and that is what is very important. Sometimes the patient is unfit for such a surgery, we have to harvest a flap from the scalp. But the results are same. Cancer of the lip, again taken from the hand, and then this is the final result. doesn't look that bad, this can be revised of course. This is a special type of flap called a chimeric flap used for two purposes. So this is also for maxilla. And fibula. We all know that we can harvest the fibula bone, or we can break the bone actually and convert it into the jawline, and when the jawbone goes away in the cancer, then we create the new jaw, create the mandible just like this, and it comes out. A very large flap. Now whatever be the resection, see this is a huge resection, and we could not give a fibula here because of the size of the defect, and the result is not that good. But the next case, this is the fibula again, and so if you see the first photo and the last photo, they do not look very dissimilar. It does not look that he has undergone such a very big surgery. A very recent case, very big fibula, and this was done, and the results are as good. Now this is, sometimes we put in a fibula and then there is we cannot put the teeth back. So this is a double barrel osteotomy in which we can put normal tooth implants, and accordingly we can do it. Skip flap, MSAP flaps, these are advanced flaps. So whatever may be the defect we reconstruct it. This is a heel defect we finally see. This is a double flap. Now if we go to the more interesting part of plastic surgery, that is trauma and cosmetic, we are using some modern advances also to treat some difficult wounds. This is called a dermal matrix. When there is no option of a flap, we use this. Hand injury often presents to us that somewhere they have gone there and there is a cut or a glass cut injury, and the referring doctor has stitched it back, and then there is loss of function. There are nerves, vessels, all are cut inside. They come back to us in this position, they explode, and all the tendons, nerves and muscles are readjusted, and they are done, and in 3 months time they are absolutely fine. Cleft lip has always been plastic surgery's forte. These are my results. These are like as little scar as possible with plastic surgery methods. Congenital hand is called a part of pediatric plastic surgery, where we can actually do the syndactyly. Hand replants, we just have a session on hand replants. So this plastic surgery. Cleft hand, very common pediatric plastic surgery. These are the results. Diabetic foot, we have many endocrinologists here. Diabetic foot is what we are doing is we are doing some special surgeries. So some special surgeries in which the pressure on which when the leg is falling on the pressure is deviated. The pressure is transferred to some other place where you can actually prevent the recurrent ulcers that we often see in diabetic foot ulcers. Tendon Achilles repair generally do not come back normally, have to put some form of flap. Speaking from experience, most tendon Achilles repair finally end up with a flap. Thumb reconstruction, all hand injuries, they are a plastic surgery, all sorts of hand injuries. Sometimes you require flaps, sometimes you don't. So this is an interesting case. If we can just pay attention to this, the patient had come to us with a Fronius gangrene which has been debrided almost 20 times outside, and we presented the face like this, and then we did this first part we had to just bring in the testis down, and then finally with a flap, this is the final result. If you see the first and the second, it doesn't seem that he had such a huge defect on the other side. Breast reconstruction most commonly is done with a graft. You just take out the foam and put in a graft, or you just close it. What we are presenting now is a newer advances. We are doing a DIEP flap, that is a flap taken from the abdomen. If you see, this was the defect, and then 28 into 15 centimeter flap was taken from the abdomen. Most people have the belly has been taken along with the blood supply, and this is the result of. So the patient goes back with her dignity intact and doesn't have to say that my breast is gone. Nobody basically knows. This patient was operated, and the nipple was created later. I don't have the photos for that. But DIEP flap reconstructs the whole breast naturally. Keloids, we all say keloids have no other option, but keloids, yes, we have an option. We excise the keloids, and then we do scar therapy on them, we do lasers, we do other therapies, and sometimes the keloid does not come back. At least 60% of the cases we see the keloids do not come back after excision. Plastic surgery is all about getting good scars from here to here. We have to see.
You have 2 minutes left.
We'll just move on.
2 minutes left.
Structural fat grafting on the face is a cosmetic, more interesting. These are dark circles. We often see people with dark circles, under eye pigmentations, and for that dermal fillers, nano fat grafting. We are doing fat grafting for dark circles. If you see the before and the after photo, this and this. So the dark circles, they are gone. Eye bags, very common. Eye bags, blepharoplasty. We treat them, under eye bag removal. Facelift, the before and after photo, if you see, this is the difference. Rhinoplasty, nose job, plastic surgery. Before after photos. This is a Botox treatment. If you see the before and the after, see the forehead, the wrinkles are absolutely gone. Tummy tuck, see the difference we are getting from the abdomen, the size. Breast augmentation with implants, size of the breast before after photos. Gynecomastia we are doing at a regular basis. Gynecomastia liposuction only, no need of even excision, hair transplants, chin augmentation. If you see the microblading treatment, see the forehead before and after. See the change in the eyebrow. See the change in the eyebrow. Color of the eyebrow has changed. It's better and it stays for 5 months. 5 years actually. Regenerative therapy is the future. SVF therapy, exosomes, platelet-rich plasma. Now scar therapy. There are some points which I don't have the time to read them out. But avoid sunlight, massaging, silicone sheet, helps in scar therapy. Some daily purpose here. So if you can, anybody in this room can understand what surgery has this patient undergone before and after. Nobody, it's very difficult actually to understand. So before and after, this is that surgery. The entire mandible is gone. Plastic surgery touches millions of lives around the world each day, bringing a smile to those inflicted with disease and deformity, changing their lives for the better. It's an amalgamation of science, arts and crafts to replace the form, function and aesthetics of the human body. Plastic surgery brings back, refashions and restores to wholeness the features which nature gave but chance destroyed. It is never the surgeon alone, but it is always my team. Now, no surgeon performs alone, it's always with the team. Thank you very much.
Thank you.
Breezing through the session like Bombay Bharat Express. Now I request Dr. Basu and Dr. Mojumdar to come on to the selfie zone. Dr. Rajesh Singhal, Executive Committee member of the Family Physician Association, to present mementos to Dr. Sabyasachi Basu and Dr. Kinjal Shankar Mojumdar. Amidst a loud round of applause from the audience. Dr. Kinjal Shankar Mojumdar and Dr. Sabyasachi Basu to receive the memento from Dr. Rajesh Singhal, Executive Committee member of the Family Physician Association.
I will request Dr. Ritesh Kontia, who will be talking on evaluation of kidney diseases, a case-based approach.
This session is supported by Intas Pharmaceuticals Limited. We thank them for their support.
Yeah. Good afternoon, everybody. First, at the onset, I would like to thank the organization for having me here. And I'm Dr. Ritesh Kauntia. I'm a nephrologist, and I'm in Fortis Hospital. Today, I'll be talking about evaluation of kidney disease, a case-based approach. Kidney is an organ which is affected late, and that is why my session is a penultimate session, because kidneys, after it goes from endocrinologist to cardiologist, then it comes to the nephrologist when the creatinine goes up. So I will be giving you an overview what is a kidney disease, how do we evaluate, and I will be going through some of the cases which we have worked up. Kidney disease has become a challenge because of increasing diabetes, because of increasing hypertension, because of increasing obesity. And every day there are around 2 lakh patients who are requiring renal replacement therapy. It is said that in diabetic patients around 33% have a risk of developing chronic kidney disease over time, and in hypertensive patients around 20% patients will be developing chronic kidney disease over time. When we say chronic kidney disease, it is basically any abnormality of structure or function which has been present for more than 3 months, and it has implications for health. So if a patient has a low GFR, that is when the GFR is less than 60, along with other markers of kidney damage, that is albuminuria, urine sediment abnormalities, electrolyte imbalance, if there is something on biopsy, if there is a structural defect on ultrasound or a history of kidney transplantation, the patient is said to be having chronic kidney disease. Whenever we evaluate a patient of chronic kidney disease, what we see, define it on the basis of CGA, that is the cause, the GFR, the albuminuria. cause is very important because it decides what will be the trend over the next 5, over the next 10 years, and how fast you will require renal replacement therapy in the future. The causes are divided.
May I request, please to be silent. May I request, please, few minutes. Just bear few minutes with us, please.
The cause is basically based on whether it's a glomerular disease, tubular interstitial disease, vascular disease, and then we divide it on the basis of GFR, which is basically from G1 to G5 and albuminuria A1 to A3. Why this is important is that if we take only GFR or if we take only albuminuria, we will be not classifying the patient correctly. What we have to do is that we have to identify the high risk patients who have a high risk of a progressive chronic kidney disease. That's why both combination is required. So if we look at this GFR and if we don't take albuminuria into consideration, the patient will be into moderate risk or very high risk depending on the albuminuria, which we won't be taking into consideration. And if we take this albuminuria, then depending on the GFR, the patient's risk will change. That's why we are supposed to combine all the three factors and then we have to describe the risk for the patients. How do we calculate the GFR? The GFR is calculated based on the CKD EPI formula 2021, and normally what we do is that we measure the creatinine value, age and the sex. Based on that the GFR is calculated. Problem is that creatine is variable. If somebody has a very high body mass, muscle mass, then the creatine will be falsely elevated. If somebody has a very low muscle mass, then the creatine will be falsely low. So in those patients, cystatin C is a measure which is not affected by muscle mass, and that is used in those cases in which we have a doubt that we may be having a false creatinine, and that's why the GFR will be falsely elevated or low. That is the time when we combine both creatinine and cystatin C. The values and the classification will change whether it is a albumin or whether it is a protein which we are detecting. That is very important because less than 30 what we talk about ACR, it will be less than 150 for PCR. That is very important. Now the risk, as the GFR decreases and as the albuminuria increases, the risk of all-cause mortality, the risk of cardiovascular mortality, the risk of end-stage kidney disease, the risk of having acute kidney injury increases, and that is why we are concerned when the GFR goes down, when the albuminuria increases. How do we evaluate a patient with kidney disease? We should always think that it is not, it is an art. Basically, medicine is an art, and whenever we see a patient, we should always take the history properly. We should always take the history whether he has any comorbidities or not, whether patient is taking any drugs which can be affecting kidney disorders, whether patient has any family history of kidney problem or any symptoms. That is why it is very important that based on the factors which the patient is saying, we do certain tests. What do tests we do? We always calculate the GFR, we always calculate the ACR to re-stratify these patients, but we should always try to find out the cause. For that, imaging is required. Based on the imaging, we decide whether further imaging is required or not. Sometimes we have to do invasive tests like kidney biopsy, which is also required many a times in our nephrology practice, and we do get surprises. I will be going through certain cases which will help you out. Certain laboratory investigations, because what we see is that vasculitis, then we have like membranous nephropathy. Those tests, certain tests can be done which can help us in detecting these diseases. SLE. Then myeloma can be detected by certain tests like comprehensive myeloma profile. A urine analysis is a short of kidney biopsy which we do, and nowadays what is required is genetic analysis also, which we are doing for many of our patients. So earlier, many of the times we were not classifying the patients correctly. So in certain cases like hyperoxaluria, certain cases like cystinosis, certain cases like Alport syndrome, and certain cases like ADPKD, genetic testing has come to the fore, and we are using this test very comprehensively in our clinics nowadays. Now I will be going through the certain case series and try to evaluate how do we go about managing these patients. This patient is a 68 years old male. He has hypertension. He is on telmisartan and amlodipine, has dyslipidemia on fenofibrate, coronary artery disease, and on evaluation was found to have creatinine of 1.4, GEGFR of 55, and the patient was labeled as chronic kidney disease. This is a routine scenario which you would be seeing in your clinics day in and out. So what do we do for these patients? Do we give this patient a nephrosafe and say continue the other things? Do we give soda bicarb and tell him to continue everything which is routinely done? Or should we evaluate for the cause, or we should try to adjust the medications and follow up? One thing is important, that telmisartan can cause increase in creatinine, fenofibrate can also cause increase in creatinine, but I want to bring forward certain things, that is what is called a aging kidney. As our age increases, the GFR of the kidney increases. Every decade we lose around 8 ml of GFR every decade. So based on the current criteria, it is said that more than 50% of the patients who are more than 70 would be labeled as chronic kidney disease. So are we labeling them right? Whether we are detecting them, or we are over labeling them as CKD, or we have to have better tools to detect chronic kidney disease. As you age, there is arteriosclerosis, there is glomerulosclerosis and tubular atrophy, and what you can see in the percentages, as the age increases, the sclerosis and the interstitial fibrosis increases. That is why the patient's GFR decreases over time. There was a study in which they have brought in the concept of age-adapted GFR. That is, if the age is more than 65, then the cutoff should be less than 45. And if the age is less than 40, then the cutoff should be less than 75. This is because at a younger age, the risk is higher, and at a higher age, the risk is lower. And what they could see was the percentage of patients who were defined as CKD decreased from 5.9% to 3.6%. So maybe we have to look, because we have an aging population, because patients are living longer, because they are having diabetes and hypertension. That's why we should be careful while we are labeling them. So it is said that because when we are using this fixed threshold definition, 60% of the patients are being detected to have chronic kidney disease, and that is why we should be labeling them properly. So if you look at this diagram, this is for the younger population, this is for the older population. In the GFR range, that is 45 to 59, the risk is less in the elderly population as compared to the young population. So in the young population, you should be more careful, you should be over detecting, and in the LD population, we should be more careful that we will be labeling them as chronic kidney disease, because these may also have insurance fallouts, because their insurance can also get rejected. But still, this is not in the guidelines, so it will be difficult to label them differently, it will be difficult. Here also what you can see that in the elderly population, what you can see that the risk of death is higher as compared to the risk of end-stage kidney disease. The patient, that is, the patient will die before the patient reaches end-stage kidney disease and requires renal replacement therapy. So that is why we need to be careful while labeling them. So do we have certain tools by which we can detect that? Actually, the cystatin C which I was talking about, it is not recommended in this elderly population, because in this elderly population, what happens is that there is arteriosclerosis and there is inflammation, because of which this is not recommended. The cystatin C will be falsely elevated in this population, so this is not recommended. What is recommended is a measured GFR. Normally, we have to do timed excretion of iohexol, inulin, creatine, EDTA, which is not available routinely. So what we can use is 24 hours creatine clearance, but this is also cumbersome. Sometimes it is not collected properly, so you may not get a proper value. What is important is the urine albumin creatine ratio. That is a good sign. If it is normal, then you can tell that the patient can be less assured. But if it is elevated, because this can be also falsely elevated, because the creatine will be on the lower side in the elderly population, and that is why a 24 hours urine analysis will be important in these patients. And if this is abnormal, then only you should think of labeling these patients as chronic kidney disease. And if it is not abnormal, then maybe you can just follow up these patients, and you can use an age-adapted definition for labeling as chronic kidney disease. Now coming to certain cases of myeloma series. Myeloma is an important disease in which kidneys are one of the important organs which are involved. Earlier, like we used to define as NGUS, that is it is not important to treat. Smoldering myeloma, which is not important to treat. When the patient had multiple myeloma, then only they were treated. Then there was a definition called monoclonal gammopathy of renal significance, in which there is a monoclonal and the gammopathy is there, along with only kidney involvement is there, and this becomes a basis for treatment. So whenever you have a patient with a kidney disease and a M-band, then always you should think about MGRS. Myeloma affects all the organs, and the myeloma defining events are the CRAB criteria which is usually used. Kidney can be affected by multiple ways, by non-immunological factors and by immunological dependent factors. The immunological dependent factors which we are concerned about are the organized deposits, that is amyloidosis, fibrillary glomerulonephritis, C3G, and the cast nephropathy, which is most common. MGRS has become the diagnosis, and it has become a treatable condition which was not treatable before, and we are diagnosing this much and much more commonly nowadays. I am putting forward a case of a 52 years old female. The patient had hypertension, had a raised creatinine, and had just generalized weakness. On evaluation, the creatinine was 4.8, the urine routine was bland, ultrasound was normal sized kidneys, and the patient has raised cortical echogenicity. Normally, many a times in the periphery, the patients are labeled as CKD, started on dialysis, and just move forward. We evaluated for the cause. We did a kidney biopsy, and what we got was a normal glomeruli, and we could see the fractured cast, which was past negative, and so a diagnosis of cast nephropathy was made. We further evaluated the patient for myeloma. Myeloma was positive. The patient was started on chemotherapy, and the patient's kidney function improved. Many times it can be said that we could have done a comprehensive myeloma panel before, but many times that time you don't have. Time, as we say, the time is brain, time is kidney. So the earlier the diagnosis you make, the earlier you can treat these patients. And this biopsy, after doing the biopsy, after we could see the cast, next day only we had started the patient on DEXA after doing the bone marrow, and the bone marrow was also positive. Cast nephropathy is one of the most common causes of kidney disease in myeloma, and that is treated usually by removing these free light chains by aggressive chemotherapy. And many times, certain times we also use certain high cutoff dialyzers in which we can remove those free light chains and can reduce the risk of kidney disease in these patients. If the renal recovery is there, the survival is better in patients with myeloma, so early treatment is the therapy of choice. The second patient, he was in gastroenterology, he was showing to a gastroenterologist who was working up this patient for chronic diarrhea. He had weight loss.
Dr. Ritesh, please sum up.
Yeah,
2 minutes.
and he found to have proteinuria, and when the proteinuria was there, they found he was referred to me. When I did the kidney biopsy, what was there? He had AL amyloidosis. So basically, amyloidosis is a disease which can affect many of the organs, and as you can see that kidneys, heart, bowels, and the liver can be affected. And this patient had GI involvement, heart involvement, and kidney involvement. Bone marrow was done, and the diagnosis was made, and the patient was treated with chemotherapy. That patient was also having a hypertension, was a raised creatinine, ACR was high. He was evaluated, SPP was positive, so I did a kidney biopsy, but to my surprise in the kidney biopsy it was only hypertensive nephropathy. That's why in kidney biopsy electron microscopy is one of the important techniques, tools which we use so that we can differentiate. Many of times we see hypercalcemia patients. Hypercalcemia patients are common in everybody's OPD, and certain times they throw up a surprise. This patient, elderly patient, was admitted under a neurologist, was having raised creatinine, hypercalcemia. Initially we thought it was vitamin D related. We did the initial evaluation, PET CT, electrophoresis was negative. Then we did it with denosumab, the patient improved. But in follow-up, again the calcium went up, creatine went up, myeloma profile was negative, and on further evaluation, when we did a bone marrow aspiration and biopsy, what we got was a sarcoidosis. So sarcoidosis is a disease which can affect the kidneys through direct involvement or by hypercalcemia involvement. So that is why you should always keep your eyes and mind open whenever you are seeing a patient. He was a patient who had come to me for a raised creatinine. Normally in our clinic we would have labeled him as a chronic kidney disease and could have treated. Calcium was only 10.4, PTS was 68. But on further evaluation, what was to my surprise was the calcium was always remaining on the higher side after reducing the calcium intake in the diet also. What I did was a parathyroid scan, and this patient had a primary hyperparathyroidism. I started the patient on Cinacalcet, the creatine came down, calcium came down, he is doing better, has been advised for surgery, and he is awaiting surgery. So many times it is said that we should always try to evaluate for the cause of kidney disease, because if we don't evaluate for the cause, we cannot, if you don't treat the cause, the kidney disease will progress and the patient will land up on dialysis. That is why it is very, very important. Nephrology is like medicine. It is not science but art, and we always try to find the needle in the haystack. In our busy OPD, where we are seeing 30-40 patients, we get 2-3 patients in which we can find this diagnosis, and that is our job, to find this diagnosis so that we can treat the cause and prevent these patients from landing up in chronic kidney disease and end-stage kidney disease. I would like to thank the organizers for giving the time, opportunity. I am there in Fortis Hospital, and I also like to thank Intas for sponsoring this session. Thank you so much.
Thank you, Dr. Ritesh. Thank you.
Chairpersons, please give me 2 minutes time. Dr. Kauntia, please come down to receive your memento. The oldest surviving member of the Family Physician Association and an executive committee member, octogenarian Dr. Saroj Kumar Ghoshal, will present the memento to Dr. Ritesh Kauntia. A loud round of applause both for Dr. Ghoshal and for Dr. Kauntia. Dr. Ghoshal has made it to the conference in spite of his age. He is still serving as an executive committee member of the Family Physician Association, Kolkata. We are very proud of him, Dr. Kauntia and Dr. Saroj Kumar Ghoshal. Now, for the most important session of the day, Dr. Shankarata to invite the speaker.
I will invite Dr. Mary D. Cruz, who is going to talk on medical ethics. So without this session, the whole CME is incomplete. We had to complete this session, and we will then only be getting the medical
Credit points.
credit point certificate. Thank you very much. Dr. Cruz, please.